Hi everyone, I am Tasneem Arsiwala, a graduate student from Dr. Paul Lochman's laboratory at West Virginia University. Today I'm going to present my poster on the impact of low intensity focused ultrasound on the tracer accumulation across the blood-brain barrier in a preclinical model. So we know that drug delivery to the CNS, specifically the brain, is very difficult because of the presence of the blood-brain barrier, which is a formidable barrier and prevents the accumulation of drugs and other external substances into the brain. Recently, the technique of low intensity focused ultrasound has been investigated as a non-invasive alternative to improve passive drug delivery and accumulation within the brain for various pathologies. In this poster today, we will present about the use of low intensity focused ultrasound to disrupt the BBB in a preclinical model and the characterization of the parameters of the focused ultrasound. Here is our experimental model, and in figure 2, you can see the experimental setup. In this case, we set up the animal, used a custom-made 3D printed animal holder, which allowed various modifications based on animals' weight and size. And then this was placed within the transducer of the focused ultrasound with the mouse's head partially immersed in the water. We administered different tracers and measured the effect of the cavitation dose and the microbubble dose on the blood-brain barrier opening. So first, we wanted to qualitatively see whether the BBB was open using our technique. In this case, we've used a 3 Tesla Siemens MRI coupled with the Insight Tech technology for focused ultrasound mediated disruption. In figure 3, we saw the histological verification of the blood-brain barrier opening. We first see the MRI images in panel A, where there was no BBB opening that was taken before the administration of the focused ultrasound, and B, the red arrows mark where the gadolinium enhancement took place after focused ultrasound. In this experiment, we had also administered 2 tracers of different sizes to measure the extent of opening of the blood-brain barrier. And we see that the smallest tracer, which is AIB or amino isobutyric acid, accumulated maximally as seen in panel E, followed by Texas Red, which is a 625 Dalton molecule in figure C. And then the largest dextran, which was the 10 kilodalton dextran, did not permeate as much as the smaller ones. Finally, in panel F, we saw that the crescent violet staining showed no macroscopic damage. And we quantified the accumulation of these tracers and found that there was a size-dependent accumulation within these mice after focused ultrasound at the dose. Next, we wanted to evaluate the amount of accumulation based on cavitation dose, which is what we see in figure 4. We saw that there was a dose-dependent increase, where an increase in cavitation dose produced an increase in the accumulation of the tracer distribution within the brain. And this was also size-dependent. So the smallest molecule, AIB, as you see in A, had the highest accumulation, followed by B, which was Texas Red, and C, that is 10 kilodalton cascade blue molecule. Here we also saw that for the higher doses, which were 1 and 1.5, we saw erythrocyte extravasation as seen on the staining here in panel E. So for our future studies, we've mostly stuck with the cavitation dose of 0.3, which seemed to be the most safe based on our macroscopic histological analysis. In figure 5, we have demonstrated the relationship between microbubble dose and accumulation of tracers within the brain after focused ultrasound mediated blood-brain barrier disruption. Again, we've seen and confirmed our results with what was seen before, where the microbubble dose correlated with the extent of blood-brain barrier disruption and tracer accumulation. And this again was size dependent, where in the smallest tracer accumulated in the highest concentrations. So with this study, we have seen that focused ultrasound has a potential for increasing efficacious delivery into the brain especially for other pathologies like brain metastases. We saw that the blood-brain barrier opening with focused ultrasound, especially low-intensity focused ultrasound, is highly size-dependent, where the smallest molecules penetrate easily because of the physical disruption by the focused ultrasound. And we see that there is a dose-dependent increase for cavitation dose and the microbubble dose. We still need to understand, first, the time dependence of this focused ultrasound-mediated increase, and B, the secondary reactions that take place after the blood-brain barrier disruption is complete. In conclusion, we've seen that focused ultrasound is a good non-invasive alternative, which is a reliable technique for blood-brain barrier disruption and can potentially improve the distribution of drugs within brain and the brain metastases. These are our funding. And I would also like to invite people, if they are more interested, to refer our paper, which has been published in the Fluids and Barriers of the CNS with this data. Thank you. Please feel free to reach out to me with any questions or Dr. Lockman, and our emails are mentioned in the poster as well. Okay.